Don Berwick, one of the United States' leading advocates for high-quality healthcare, was the keynote speaker at the 2013 Signature Health Policy Forum. His presentation, Leading Healthcare Reform Together, was followed by a Reactor panel discussion featuring 4 healthcare leaders from across the nation. The following are excerpts from that discussion, moderated by St. Louis radio host Mark Reardon.
Well, first I wanted to say what I'm the president of at Humana, and that's senior products. And senior products at Humana equals Medicare Advantage. When I think about healthcare reform, I think about, is this a windfall for Humana, or is it just a lot of win? And I think it's kind of a combination. With healthcare reform comes some headwinds for us, headwinds in the form of premium tax, headwind in the form of reduced reimbursement for our Medicare Advantage programs, because some of that money is being used to fund the exchanges and the healthcare reform. A phasing out of some of the STAR rewards programs that have been available for health plans to improve the quality ratings. And of course, then there's the sequestration, which isn't really part of ACA, but it certainly is impacting our entire industry.
I'd like to congratulate everybody in this room for coming here. All of the different stakeholders here together in a room. I've been at this for almost 20 years, and 20 years ago, you couldn't bring all the stakeholders together in the same room and have a conversation about quality, no less cost. So you're to be congratulated for coming together to talk about these very important issues. I come from Rochester, New York, where we work on consensus every day, and it's really hard work, and there are no silver bullets.
My name is Bob Hinkle, and I'm a Pirate fan. I know there are 12 steps for that, but we're going to...
That's the Cubs.
That's true. As was mentioned, I am the President and Chief Executive Officer of Ascension Health. Our mission is simply to provide holistic care to everyone in the community with special attention to the poor and vulnerable. And we do that in a manner in which we're looking to create sustainable health care. We are also advocates in both our actions and our words for a compassionate and just society. A lot of that doesn't talk about health care. We've talked about the transformation of health care, and Don was talking about many of the issues that we're facing. In our organization, and I can tell you that there are many people, even in our organization, who take issue with me at times, but I believe and define the transformation of healthcare in this country is when hospitals are simply cost centers, and our physician caregiver enterprise is the way we reach out to the community. That is a very different model of care than we have today, either within Ascension Health or certainly within this country.
I'm Jan Vest, and I'm the CEO of the Signature Medical Group here in St. Louis and Kansas City. The mission of the group, I think, is evident here today. We provided the seed funds to start the Signature Healthcare Foundation because the physicians of Signature really believe that compassionate care and outreach, access, and lowering cost is important to our community. We see over 500,000 patient visits in both St. Louis and Kansas City, and the physicians and the nurses are in the exam room with patients facing illness and disease, and see what an impact a dysfunctional and too expensive healthcare system does to the families of our communities. We're the only private practice group in the country that is participating in the bundled payment initiative with Medicare, and we are doing that in Kansas City, St. Louis, and also with an affiliate group up in northern Illinois. So our physicians understand that the transformation of the healthcare system is going to be difficult. But we want to be part of that transformation and be a positive force for change, and really hope that our discussion today and the work we're doing in the communities that we serve can create positive change.
Let me start with this question. Dr. Berwick, outlined his thoughts exceptionally well in the presentation that we just saw. But I'm curious to get the panelists' thoughts on what he said, and specifically on the barriers that exist from your perspective to improving the system. Anyone want to start with that?
I'll start with one of the barriers that he talked about, the business transition barrier at the very end, because we spend a fair amount of time in our own organization thinking through that. And I think about it from an economic standpoint across this country, the amount of debt that's held in tax-exempt bonds that is based on being paid back through the hospital revenues is a major barrier to some of the transition that we're talking about. Because how do you pay that debt back? That debt's held in retirement funds that probably everybody in this room would be impacted to the extent that there are defaults on that debt. So somehow we have to think about the transition in a way that allows that debt to be handled appropriately, and at the same time be bringing down the costs that are going forward. And I would put out there that one of the ways to get there more quickly would be to move away from this in-between time where we continue to have payment based on procedures and fee-for-service and move more quickly to a fee-for-value. The opportunity, the waste will come out, so I believe there will be plenty of money to pay back that debt. Yet it gives us the ability to move and incentivizes the whole system to move in a different direction. There are a lot of people who don't want that to happen, but I think that's an issue which I see as a huge barrier and a disincentive right now to some of the things that Don was talking
So
about.
how do you get to fee for value then? What needs to happen?
Well, it moves away from, use the bundled payments. Why not go to all bundled payments?
I'll take, I think it was number 6, and that was require innovations to prove their worth. I mean, in our business, you go to the CFO and there's an investment line, and if what we were proposing doesn't give us a return, we don't do it. So there's lots of things coming out. There's lots of marketing by lots of companies to do new things. We got to require seeing the evidence that it matters, that it's better than usual care, because otherwise, we're spending a lot of money, and examples that Don gave of things being, 50x just because it was patented. We need to figure out how not to spend those dollars. From the Medicare data that was released several months ago, from a study, for example, in California, that the variation in the price of a colonoscopy can be as much as 10x. And so we tell our employees, go out there, but they don't know what those amounts are. So we need help in terms of getting the real costs out there. And I think that there's a partnership to be built with the physicians and the hospitals on this because of bad debt. With people getting into high deductible plans and having to pay 20, 40, whatever it is % of the bill, and not knowing what the bill is, okay, so they have the service, and then they see this bill that, by the way, they had no imagination that could possibly be the case, that it's a $2,000 bill.
We don't dictate prices to physicians. Those years are gone. This is hospital systems in particular really leverage price. They've consolidated physicians. They've consolidated markets. You can't be in certain markets without certain facilities, certain IDS. So I really take issue with your opinion about that. And then in the senior products area, we really kind of follow the lead of what Medicare does. There's millions of people who are in original Medicare. If you can take that price from the government, then you can take that price from a private pay or an MA plan. So we really follow that lead. Consumer-directed health plans, high deductible plans, whatever terminology you want to apply to those, they have been around in the markets probably 4 and 5 years. They were kind of slow on the uptake. I think a lot of companies embraced them. Some companies didn't. The issue about bad debt relative to the deductibles and so forth has really come back to health plans too, because a lot of the providers said, you created these health high deductible health plans. People don't know what they're owed, and now you need to pay us more because we're not collecting from them. So it hasn't seemed to have the effect perhaps that we expected it to.
Two things that we've done here. One is we responded to a plan request to develop a low back pain protocol that was available after hours to avoid unnecessary emergency room visits, which turn into train wrecks and from the cost standpoint. So we opened an after-hours orthopedic clinic that's open from 5 to 8:30 every night, and on Saturdays from 8:30 to 2:30. And it's a walk-in orthopedic clinic, and it eliminates emergency room visits every single day. We're seeing over 300 patients a month in it now. Another program we've done is with, I think I mentioned this last year also, with the Carpenters Union, where we developed with the Carpenters Union an incentive program because we got our claims data on our orthopedist against the orthopedic network here in St. Louis, and they were able to validate that our costs and outcomes were superior. And so we then developed a case management system that made it possible for carpenters, if they called our case manager, could get right in, and if they were compliant with the treatment plan, then the Carpenters Union turned around and wrote them a check.
Question for Mr. Vest. If you're able to articulate a few of your programs in the bundled payment and some specifics as to disease conditions or procedures, and any comments about where it's really been effective and where you've run into some challenges.
Well, the bundle payment program with Medicare we don't start the program until January. We have, the government is very, not difficult, but complex to deal with. So we received the award 2 years ago and have been going through the process of getting data from the markets where we will be working the program. And so the implementation date is January 1st. We also, the variation in the data is amazing. And I'll give you one example. The highest cost in a 3-year period for a total joint replacement for a patient was $150,000. And when we dug into why was the cost $150,000, how could it be $150,000, you can imagine what we found. And it was, after we saw it, it was obvious. The patient was a non-compliant schizophrenic who without any structure at home. So she went in and out of the hospital, where now, because of this bundle payment approach and the care team approach that we're developing, that patient, that complex patient with that comorbidity will be followed continually through the process, and probably will have a better chance of receiving care at the appropriate level of service with the appropriate provider of care after discharge, where in this instance, in many instances, in emergency rooms every day across the country, the same incident is happening. That because of a lack of mental health services and case management services, you have patients who unfortunately are unable to participate in a healthy return to good health because of another comorbidity that's part of their life.
This morning I told this example. One of the community health workers comes back and, you know, the person's got high blood pressure, and so what do you tell them to do? You tell them to eat right and exercise. Well, eating fruits and vegetables, and they give this example of broccoli, and the person looks back at them and goes, I've never seen broccoli, what's that? And so I tell them, and so they say, well, okay, so they actually took them to a grocery store, showed them what broccoli was, and then they said, well, how do I cook that? Well, they showed them how to cook that. So what you and I and most of the people in this room take for granted, we got to get, you know, really basic. And so we're trying to figure out how can we scale community health workers in Rochester to get at everybody because, you know, it's our community. It's going to cost us dearly in human terms if we don't get to everybody in the community.
St. Louis is a great example. There are too many hospital beds in this city. I mean, why would anybody want to bring another hospital bed? Yet I see cranes all over the city.
That hasn't been an issue that Jan's ever addressed, so he's shocked by that, I think.
And I said earlier that's something that we've taken a very hard look at, is that we're not interested in building more hospital beds. We just see them as costs in the future, and unless someone can pay for those in 3 to 5 years, then you better think twice before you go down that path. Yet, you know, we need the newest and brightest and best and fancy lobbies, and that until, you know, there's a lot of community pressure that's going to take to get some of that done.
The increasingly important conversation of healthcare reform will continue at the 2014 Signature Health Policy Forum. Please join the discussion by attending the 12th Annual Forum, Fall 2014.